السلام عليكم. صباحكم الله خير. بسم الله الحمد لله والصلاة والسلام على رسول الله. بناء على توصيات وزارة الصحة وعلى الوضع الحداد العام في الكويت ما راح يكون في اوبننج سيرموني، فراح نباشر على طول ان شاء الله بالمحاضرات وانشطة المؤتمر. فبسم الله تفضل عبد الله. شكرا.
So the first lecture today will be given by Dr. Abdullah Al-Bazzaz. He's a senior specialist working in Al-Jahra Hospital as a head of hand department. He did his fellowship in Ogori Daiichi General Hospital, Japan, Yamaguchi. And he will be giving the first lecture about Lacertes syndrome.
Bismillah ar-Rahman ar-Rahim. Good morning, everybody. Today I will talk about Lacertes syndrome. It's a condition that is not well recognized in most of orthopedic surgeons and some of the hand surgeons. So it's basically to have awareness about this condition. So what is Lacertes syndrome? So Lacertes syndrome is a compression of median nerve in the proximal forearm and caused by Lacertes fibrosis. As we all know that median nerve can be compressed along its course in the upper limb from the brachial plexus site up down distally to the transverse carpal ligament. We know that after carpal tunnel release, we have about 80% of patients will have good to excellent results. However, we have about 10 to 20% failure cases. So what is the causes of these failure cases? Is it the diagnosis or is it the treatment we offered? So as I mentioned that, we have one of the pressure points is the Lacertes fibrosis. So what is Lacertes? In the English dictionary, it came from the word lacerta, which is the meaning a lizard. However, in anatomy, the Lacertes is the aponeurosis extending from the lateral border of the biceps tendon, going medially and blend to the flexor muscles and covering the antecubital fossa. They give the word Lacertes as a lizard because it resembles the tail of the lizard. First time I encountered with this condition in the literature was in 1978, and it was reported as a case report. From 1978 till now, there is a little in the literature about this condition. However, as we can notice that there is increase in the publication in the recent 5 years maybe. How common is the condition? I couldn't find in the literature about the prevalence and incidence of this condition, but the closest is that carpal tunnel syndrome with the proximal median nerve entrapment, it accounts about 13% of all conditions. But according to Dr. Haggart, which is a Swedish surgeon working in Espitar, Qatar, she did about 500 nerve decompression in 3 years, from 2018 to 2021. And she found that 40% of her cases due to Lacertes syndrome, either it is isolated Lacertes release or combined with carpal tunnel. When we suspect to have a Lacertes patient with Lacertes syndrome, so any patient with the carpal tunnel syndrome symptoms, you have to examine for presence or absence of Lacertes syndrome. Second, carpal tunnel syndrome with negative EMG. Patients undergone carpal tunnel release with not satisfied after the release. You have to suspect he may have a proximal entrapment. Patient complain of loss of endurance and strength during work. If patients start to experience pain during work, and this is intrinsic muscle like cramps, the ulnar nerve supplying muscles, as a compensation for the weak median nerve supplied muscles. Any occupation that involve a pronation of the forearm and repeated finger movements, like orthopedic surgeons or surgeons in general, musicians, computer workers, and athletes. What are the symptoms? Numbness, it's considered to be common if it is associated with carpal tunnel syndrome. However, if we have isolated Lacertes syndrome, numbness could be very minimal in these cases, as you can see in this. In the isolated, it's very little to have a numbness. but they're very, very common to have loss of strength and loss of endurance. This is the most common symptoms of patients with Lacerta syndrome. In examination, patients will experience tenderness in the proximal forearm and repeated numbness when you press on the Lacerta fibrosis. Usually they have negative Fallon test if it is isolated Lacerta syndrome. Muscle testing, they will have experienced weakness of the flexor carpi radialis, flexor digitorum profundus of the second digit, and flexor pollicis longus. And they will have positive scratch collapse tests. As we can see in the topography of the median nerve proximally, the fibers or the axons of the FCR, FPL, and FDB2 usually superficial, and they are very close to the Lacerta's fibrosis. So that's why the patient will experience weakness. Scratch collapse test, according to the McKinnon, who described this clinical examination, the sensitivity of this test for any entrapment of any nerve, it can reach up to 90%. How it's done? We apply physical irritation like scratch over the suspected area of nerve decompression. If positive, there will be temporary loss of voluntary muscle contraction. And we have demonstration here by my colleague, Dr. Ahmed Mutwalli. He performed it in the clinic. He's applying scratch now, and then there will be a weakness. So what is the theory behind this condition? There are many theories why collapse happen, but one of the reasonable theory is that the cutaneous silent period, it's a period of inhibition in tonic voluntary muscle activity due to cutaneous stimulus, and which can be observed in the EMG if it is done. And this is, they thought this is responsible for the withdrawal of a limb in a painful stimulus. Is it Brunner syndrome? Well, classically, any entrapment of nerve in the proximal forearm, they refer it to as Brunner syndrome. But as we can see, there are different locations of pathology. It could be ligament of Strothers, Lacerta's fibrosis, Brunner teres, and arch of FDS can cause the entrapment of median nerve. And according to Tang, the only difference that we can differentiate between Brunner syndrome and the Lacerta syndrome is the location of the tenderness. Usually, the tenderness in Brunner syndrome, it's more distally between the two heads of the pronator muscle. Usually, EMG and nerve conduction study are negative in these conditions, and that's referred to the specificity of the EMG and nerve conduction study will drop about 30 to 70% in cases of median nerve entrapment proximal to the carpal tunnel. And this is because most of the entrapment proximal to the carpal tunnel, usually it's dynamic compression rather than static compression seen in the carpal tunnel. How about surgical release? Classically, the surgeon will do the lazy incision in order to remove all the compression sites of median nerve in the forearm. This is a cadaver study, showed that if you do incision of the Lacerta's fibrosis, you can drop the perineuronal pressure of the median nerve to about 80%. So most likely it will be enough to cause decompression for the median nerve in the proximal forearm. So how to perform the surgical release? You give local anesthesia around this surgical area that you want to make your incision, and then you can do it under Wallant technique if you like. And tripod grip, you apply your middle finger to the biceps tendon and thumb to the medial epicondyle, and the index finger will fall into the desired area of incision. After marking the incision, you do the skin, subcutaneous tissue, and then you will find this shiny fibrosis over the flexor muscles and incise it completely without exploring the nerve. No need to see the nerve. And this is another video to show you how it's done. This is muscle testing of the FBL before surgery. You can see there is weakness of the FBL. And then after Lacertis fibrosis incision, and testing immediately post-op, you see there is retain of muscle strength immediately after release. So Dr. Haggart, she performed 10-year analysis of Lacertis decompression. She performed about 275 in the last 10 years, surgical releases. 75% were isolated Lacertis syndrome and 25% combined double crush syndrome, Lacertis plus carpal tunnel syndrome. As you can see, there is a good improvement in the DASH score, and there were immediate muscle strength restoration in 99% of patients intraoperatively. So to take home message, Lacertis syndrome is an underdiagnosed problem and underrecognized. If you have patients with not improving after carpal tunnel release, consider maybe he is having Lacertis syndrome. Usually EMG and nerve conduction study not helpful in these conditions. Immediate retain of muscle power for after surgical release is anticipated in this condition. Thank you very much.
So, any question for Dr. Abdullah? So, Dr. Mukhtar.
Dr. Abdullah, thank you very much for focusing in this very rare situation or rare syndrome. My question is, if you have clinical your doubt and also EMG not conclusive, what about the role of ultrasound regarding the measuring the sizing of the nerve to confirm your suspicion by clinical?
Thank you, Dr. Mukhtar. Maybe it will be helpful. I didn't try it to ask for ultrasound, and you need an expert ultrasonographer to detect it. Even in the literature, they didn't put in one of the tool of diagnosis is the ultrasound, but it is a good idea. Maybe it's in the future will be a good scope for a new paper or article about this. Yes. Yes. Dr. Ali?
Thank you, Dr. Abdullah, for this interesting topic. It's interesting the series you mentioned, even it is more common in her series, Professor Haggart, than carpal tunnel syndrome. It's like 40%, and most of carpal tunnel, they have combined Lacertis syndrome, as you mentioned. Do you think is it beneficial to do routine decompression of both, like CTS release and Lacertis syndrome, if the incision is small with low morbidity?
I know thank you, Dr. Ali. I know some surgeons, they do it as a routine. But I think the rate in Dr. Haggart series, that 40% cases, I think due to she's working in athletic center in Qatar, Aspitar. So maybe athletic patients, they will have more common to have this problem rather than the usual we see in our community. So I will not prefer to do it in meantime. So I will, if the patient having carpal tunnel, I will just release the carpal tunnel. If combined or it is isolated, I didn't operate on patient with isolated Lacertis syndrome, usually combined with carpal tunnel. I will do both. Okay. Thank you very much.
Thank you, Dr. Abdullah. So the next lecture will be given by Dr. Mohammed Boushehri. He's a specialist hand surgeon working in Jabra Hospital as a head of hand unit. He did his fellowship in hand and microsurgery in Singapore National University Hospital, and he will give a talk about ulnar-sided wrist pain.
Good morning, everybody. It's an honor for me to be here. So it's a huge topic of ulnar-sided wrist pain. And you can make a conference just for this lecture. But my aim of this lecture is just to focus on how to assess the causes of ulnar side address pain and how to differentiate between each of them. For hand surgeons, this could be a little bit boring, but for the general ortho, this is very essential, especially for residents. Okay, Bismillah. So I have nothing to disclose. So last year I presented the radial side address pain, and this year is about ulnar sided. Okay, so patient comes to you with ulnar side address pain, what to do? Okay, so easiest way is to think anatomy. Okay, so think from superficial to the deepest structures of the ulnar-sided anatomy. So first of all, you look at the skin and the nerves. So what nerves can cause ulnar-sided address pain? So the most common nerves are the ulnar nerve, okay, where they come with cubital tunnel syndrome and C8 T1 radiculopathy. Next, think about tendons. So here's a hint for you. So what tendons are on the ulnar side? So we have the ECU, FCU. So what pathology comes with the FCU is tendinitis. ECU, they come with tendinitis and snapping, sometimes together. And then think about bones. So what bones are on the ulnar side? So go back to the anatomy. So from the most distal, you have the fifth metacarpal, and the most proximal, you have the ulna. So they can come with base of fifth metacarpal fracture or dislocation, triquetral fracture, hook of Hammett, ulnar styloid, and pisiform fracture or dislocation. Then think about ligaments, which is the deepest structures on the ulnar side. So what could they come with? So they can come with TFCC injury, which are very common. Could be accompanied with DRUJ injury, arthritis, lunotriquetral ligament injury, pisotriquetral arthritis, ulnocarpal abutment, or ulnar styloid impaction syndrome, and hypothenar-Hammer syndrome. Okay? So you can see it's just the ulnar side of the wrist, and you have almost 20 causes of pain. You can take a photo of that, and you can make a full conference on just these topics. Okay, so cubital tunnel syndrome. So mainly the diagnosis is clinically. You can help that with the ultrasound or sometimes a nerve conduction study. So they can present with, what do you call it, clawing or pseudo-clawing, which is pseudo-clawing is more proximal nerve compression rather than distal. They can come with paresthesia over the ulnar side of the hand. And you can check that with two-point discrimination. And you can assess that with the pinch. So you check the pinch strength, and sometimes they have Froment sign. So Froment sign is that whenever they hold a paper, instead of adducting the thumb using the ulnar nerve, they cheat by using the flexor, which is the median nerve, or the AIN branch of the median nerve. You can do the Tinel test. You could do the compression test. So look at this guy's elbow. Sorry, this is the stretch test. So you do the flexion test. So you can see that he's mainly putting a stretch over the ulnar nerve, so tightening its course. So memorize this photo because you can compare it with the other one now. So after 60 seconds, the pain and numbness will be reproduced. Okay, and you can do direct compression test over the ulnar nerve. Also, thanks to Dr. Abdullah, he went very detailed about the scratch collapse test, where the patient get weak shoulder external rotation whenever you scratch the involved compressed area. So, and it has a very high sensitivity and specificity compared to the normal tests that we know, like the compression test or the Tinel sign. Next, you have a common problem, but not as common in the laterally, because mostly, usually they come with injury rather than just a radiculopathy. So they come, always ask about neck pain whenever a patient comes with bilateral nerve compression or unusual nerve compression. Okay, so to differentiate is that when you, with the T1 radiculopathy, usually they have axillary numbness and ipsilateral Horner syndrome compared to the cubital tunnel test. You can confirm that with some diagnostic tests like Sperling maneuver, where you can externally, you can do extension of the neck and rotate it to the affected side, and you compress for 30 seconds and the symptoms are reproduced. I rarely see a hand surgeon standing from his table and doing that maneuver, unfortunately. So this should be a must whenever you suspect high compression energy, high compression nerve problem. Okay, and do you remember the shoulder, the elbow flexion test for the cubital tunnel syndrome? That test reproduces the cubital tunnel compression. However, this test improves the symptoms. So this tells you that most likely it's coming from the neck rather than the elbow. And then we have the ECU tendonitis and snapping ECU. We see that more frequently than before. So how do they usually present? So pain on the ulnar side, but you need to differentiate that from the other causes. So you need to assess that carefully. And there is one of the common tests that we use is called an ECU synergy test, where you grasp the thumb and the middle finger, and you push the thumb against, you push the thumb on radial deviation, and then you see the ECU popping out, and then you can feel it if it's tender, and then you can assess also the dislocation of the ECU. So here's a study that tells us about how good the ECU synergy test help us from intra-articular to extra-articular pathology of the ulnar-sided wrist pain, because sometimes this could be overlapped with TFCC injury. Next, we have base of fifth metacarpal fracture, as you can see on the left side, and dislocation on the other side. So just check that by X-ray. And then we have a triquetral fracture, very easily missed. So the way to diagnose that, so first of all, if you find the prominence, the first prominence that you can encounter on your wrist, so this prominence is the pisiform. Can you feel that? So you put your thumb here, and on the back of that is the triquetrium. And then sometimes our orthopedic surgeons become imaginative and draw ducks. So you draw the ducks using the scaphoid and lunate and the triquetrium, and then, excuse my language, if you see that duck, there is something called a pooping duck sign. So whenever you see that sign, that's a triquetrial fracture. Clear? Next. So we just felt our pisiform, which is the most proximal prominence. Then you go slightly distal. So this is the hook of Hamet. Okay, and they are commonly fractures with falls and sometimes with baseball players or tennis players. The tenderness there has an 80% sensitivity of a hook of Hamet fracture. You can do a pull test where you flex the FDP of the little and the ring finger against resistance that pushes the hook of Hamet away from its way, and then you can feel the tenderness over the red spot. And then whenever you see a hook of Hamet fracture, do a neurovascular exam because the ulnar nerve could be injured as well. And there is a very important view over the X-ray view. It's called carpal tunnel view. Okay, as you can see here, it shows you the bony anatomy over the carpal tunnel view, and then you can see the, where is it, the hook of Hamet here. And then we have the FCU tendonitis. So it's attached to the pisiform, and it's slightly, the tenderness usually is slightly proximal to its insertion. So one of the ways to examine that is to do a resisted flexion of the wrist, and then you can feel the tenderness over the FCU. Next, our big topic, which is the TFCC. I will not focus too much on its anatomy. So here is the DRUJ and the sigmoid notch. Shows you the different variabilities of the sigmoid notch. And then you have the anatomy of the TFCC. And you should know that the central part of the TFCC is avascular. That's why whenever you have injury in the center, we usually debride it. And when you have in the periphery, we usually repair it. Just like the meniscus of the knee. Causes of TFCC injury, they could be traumatic, secondary to falls, traction injury. They are 40% associated with distal radius fractures, especially also Galeazzi fracture. And sometimes it could be secondary to degenerative, like a positive ulnar variance. So the ulna, the distal ulna is rubbing against the TFCC, or sometimes secondary to ulnar styloid impaction syndrome. So this is, whenever a patient comes to me with ulnar side address pain, especially young patients, I immediately put my thumb into the fovea. Okay? So this is called the fovea sign. I need everybody to feel that, please. So first of all, you feel the ulnar styloid, and you go slightly more palmar. So it's between the ulnar styloid and the palmar, and the wrist should be resting over, and the elbow should be over a table. And you just feel the depression here, and this is called the fovea sign. It has a very high sensitivity and specificity for TFCC. Whenever I find it positive with everything else is negative, the ECU, FCU, all of them are negative, most of the time I don't need MRI to treat, but I just do the MRI for the sake of the patient to be convinced to wear a splint for 6 to 8 weeks. So the fovea sign sensitivity is 95% and 87 specific. Next, whenever you have a TFCC injury, you need to check the DRUJ by Ballotman test. What's wrong here? What do you think is going wrong here? So you can see that the examiner's thumb is over the styloid and the ECU. So it could be tender in that area. So that's why whenever you do DRUJ, bring your thumb a little bit more proximal. So hold the ulna rather than the head. Otherwise, it could give you false positive results. Same thing here in this picture with the piano key test. You can see where his thumb is. And then there is classification of TFCC. Here comes our clap to our occupational therapists. When they created this monster splint, which reduced our scopes because of it. The success rate of treating TFCC with a monster splint is very high. You can see on the yellow part. Okay, so this is the protocol. You wear the monster splint, or you can put a sugar tongue for 6 weeks if it's acute injury, and up to 10 weeks if it's a chronic injury. And if you still feel tenderness on the spot, then you can give a steroid and then refer to the occupational therapist to do the rehab exercise. Because of this, I rarely do scopes, thanks to them. Okay, that's a scopic technique of how to repair the TFCC. This is one of the techniques, and that's the open technique. And this is a paper shows that patients who come with a distal radius fracture and associated TFCC injury, okay, it tells you that conservative treatment is as equal as operative treatment for the repair of TFCC.
1 minute.
Yes, thank you. So you no longer need to do TFCC repair with acute fractures unless there is a bony abnormality. And then ulnocarpal abutment syndrome or styloid impaction syndrome. Here is it's called ulnocarpal compression test, where you ulnar deviate and cause and do axial load over the ulnar side, and that produces the symptoms. This is a neutral view of how to know if it's ulnar positive or negative. Here you can see on the right side that's an ulnar positive, and here it shows you ulnar styloid impaction. And pisiotaraqueal arthritis is very common. Sometimes they come. So what you see here in the arrows is the recess but sometimes the cyst is big enough to fill the ulnocarpal space, causing ulnar side wrist pain. Take home message: know your anatomy, differentiate between pathological problems, assess them carefully, then you treat them. Thank you so much.
Any question for Dr. Mohammed Bouchehri?
Okay, I think we are done. Thank you so much.
The third topic will be given by Dr. Mohammed Boulata. He's a consultant in hand unit at Al-Razi Hospital. Dr. Mohammed Boulata did many publications, especially in scaphoid and scaphoid fractures. He will be giving a talk about scapho-capitate ratio and its clinical significance.
Good morning, everybody. We will discuss today scapho-capitate ratio and its clinical application. The aim of our work is to detect a reliable radiological method to detect the scaphoid length that help to detect short scaphoid condition without cost or radiation. We have to fix some definitions. The first, what is the X-rays, or what is the view, we'll ask. Through posterior anterior view, shoulder should be abducted 90 degree, elbow should be flexed 90 degree. Lateral view, the elbow should be adducted, elbow 90 degree flexion. We can add a small pillow here to correct the radial deviation. Posterior anterior with ulnar deviation. What we will measure? We will measure the scaphoid. We will measure the scaphoid length, which is the axis, the length of axis of the scaphoid. Capitate length, it is the axis of the capitate. Third metacarpal, it is the axis of the third metacarpal. This is carpal height, which is the measurement of the carpus from the base of the third metacarpal till the edge of the radius. We did this in all views. What is the post-traumatic short scaphoid? Short scaphoid may be scaphoid non-union with a gap or humpback deformity, malunited scaphoid, acute scaphoid with volar comminution or humpback, scaphoid overstuffing means it is non-anatomical bone graft which we use to over-expand the size of the scaphoid to realignment the carpus and prevent further collapse. Some surgeons recommend to use 2 to 4 millimeters over-expansion. What is the importance of scaphoid reconstruction? If there is flexion deformity 5 degree in the distal ball of the scaphoid, we will lose about 24 degree of the wrist extension. While the scaphoid length, when restored by the graft, will establish the radial column function of the carpus and tensioning the palmar radiocarpal ligament. We put a new items to describe what we will use later on. The apparent scaphoid length, this means length of the scaphoid with the gap, while true scaphoid length is the scaphoid without the gap. Okay, the gap of scaphoid we measure by radial pillar and ulnar pillar. Now, what is scapho-capitate ratio? It is the length of scaphoid divided on the ipsilateral scaphoid length. We have supposed the scaphoid length, we multiply the capitate length by scapho-capitate ratio by X-ray magnification. What our method? We did 3 X-ray view wrist for 51 patients. 11 of them is contralateral wrist for a patient with a scaphoid non-union. 27 of them we suspect fracture scaphoid. At the end of the follow-up, no fracture. 13 patients we did to exclude intraosseous lesions. In our inclusion criteria, all patients are adults, no radiological evidence of trauma, no generalized or localized bone disease. How we can, for orthopedic surgeon, is independently measured the X-rays, Dr. Sami Gelayan, Dr. Abdullah Al-Qasir, Dr. Ikrami Talat. Statistically, we use to describe the main standard deviation, median range, comparison between male and females. The intra-observer reliability test was using inter-class correlation coefficient. Our result, in posterior view, the scaphoid length is about 2 centimeters, all we will describe in centimeters. While the capitate length is 2.24, the ratio of scaphocapitate is 0.92. While for scaphoid view, the length of the scaphoid is 2.25, the capitate length is 2.24, the ratio is 1.01. Lateral view, the scaphoid length is 2.46, while the capitate length is 2.24. Our ratio, scaphocapitate ratio, is 1.1. The main result of all ratios in all views is described here. So in posterior anterior is, as we told before, this is for scaphoid view, and this is for the lateral view. This is the reliability test. We found the third metacarpal and the carpal height are low on all views, while the scaphoid length and the capitate length has a high reliability test. We compare our result for the published paper. This is the anatomical study. In male scaphoid, this is in millimeters. It is about 31 millimeters. In female is 27. Here, MRI study, the average is 24.5. CT study is 22.5. Our result is 20.5 in posterior anterior view. In scaphoid view is 22.5. Lateral view is 42.6. Now we have many ratios, many lenses, what we will use and what we will leave. Ratios in AB, we will all exclude it because it is not near to the anatomical study. While scaphoid view, we depend on scaphocapitate ratio because it is near the length of scaphoid and has a high reliability test. In lateral view, it is the nearest ratio to the anatomical study with a high reliability test. What is the benefit when we know there is a scaphocapitate ratio? The first thing, it can help in diagnosis of short scaphoid case. Here, the scaphoid, the capitate have a length more than the scaphoid. So there are some problems. I need more investigation. This is the lateral view. There is increased scapholunate angle, so there is some carpal malalignment. This is the CT. There is a fresh fracture. It is a recent fracture, but there is gap. This is after we use or if with bone graft, the carpal alignment is regained. It can be also is used to estimate the length of the scaphoid without need to do X-ray for the other limb, especially if there is limb discrepancy or there is amputation of contralateral limb. This leads to decreased radiation and the cost of investigation, and some authors published that there is left to right difference between the scaphoid size about 1.5 millimeter. We can calculate the size of the graft before preoperatively. Here, this is the capitate length. This is the apparent scaphoid length. So if we use to calculate the supposed scaphoid length, it should be 2.45, while the true apparent scaphoid length here is 2.27. So the difference is about 0.17 centimeters. Now we have to calculate the graft. This is the radial pillar. This is the ulnar pillar. So now I have to calculate. This is the gap. This is the difference between the supposed scaphoid and apparent scaphoid length. We can add stuffing, overstuffing by 2 millimeters. Here, when we curate the non-union side, we can 2 to 3. So the radial pillar should be compensated about 1 centimeter, while the ulnar pillar should be from about 9 millimeters. What is the advantage of scaphocapitate ratio? It can easily estimate the scaphoid length without need of further investigations, predict the length of scaphoid view. The ratio is fixed because the length is different from patient to patient, so the ratio is a fixed figure. Estimates the size and the shape of the graft which is needed for scaphoid reconstruction. Reduce the cost and further investigation. A disadvantage to use contralateral scaphoid. There is anatomical difference between left to right discrepancy about 1.5 millimeter. Increase the hazard of radiation and exposure. Increase the cost of investigation. A disadvantage of our study, our limited patients. We have limited patients, limited racial and geographical distribution. We need more clinical application. It was published in Journal of Hand Surgery 2019. I'd like to thank the team of this research, Dr. Sami Al-Galayand, Dr. Abdallah Al-Qasir, and Dr. Ikrami Talat, and thank you.
Any question for Dr. Mohamed Boulata?
So, Dr. Mohamed, you basically use the apparent or the true scaphoid length?
No, apparent.
The apparent, not the true.
I have a question. You feel it is good? This ratio is good, applicable?
Thank you. First, thank you very much for this detailed presentation. The point is we see many figures and many measurements. For this, I think it's difficult. I need to ask you one question practically. What is the point practically you applied with your cases?
The first idea of this, because I have some new colleagues in our unit, I found some cases in the operation, it is need reconstruction, it is not a fixation. So I try to find a method for them to just over-investigate or still take a breath before sending to the patient to the theater. This is the first. Then when we start to work on, we make some more applications. For me, I use only scaphoid views. So I have one figure only, 1.01.
But Dr. Mohammed, I think the apparent length will be changed intraoperative. I think after you clear the sclerosis and cystic removal, the gap will be larger maybe. So maybe the apparent length will be different or the same?
I just pre-operative assessment.
Yeah, pre-operative.
I have 1 centimeter from the radial side, but when I curate, I measure again. If I need to more extend, I will not take the graft except when I curate the scaphoid first.
Dr. Mohammed, one question here. Thank you for your talk. I have just one problem. We are moving in the 3D world now, and you are still in the 2D world. So you are only looking at the view from one side, you're not looking at it in a 3D fashion. I recommend, I don't know if it's applicable or not, to compare your study with a 3D CT that you would do and then compare the results and maybe prove that this technology or this X-ray is satisfactory enough to give you an idea of the shape and the volume of the graft that you use and compare to something that you would plan on some more gold standard technique to analyze better bone in such a small and three-dimensionally difficult place.
It is a good idea, Dr. Ali, and even some published paper use the contralateral scaphoid CT three-dimensional. But I try to find a reliable and less cheaper and simple.
Thank you, Dr. Mohammed. The next lecture will be given by Dr. Ali Maqdisi. He's a consultant shoulder surgeon and elbow surgeon, was working in Al-Razi Hospital and now in KOC Hospital. He did his fellowship in Paris, France, and he will be giving a talk about lateral elbow pain.
Okay, thank you, Dr. Abdullah, for the introduction. Good morning, everybody. So we're moving up now from the wrist. We're moving to the elbow. So I think this topic is quite important because we have a lot of patients who suffer from elbow pain, and it's sometimes confusing to detect which diagnosis or what is the exact problem in the elbow causing the pain. So these are my disclosures. Nothing is relevant to our talk today. So this is the scenario. We have some of our patients, they come to the clinic and they point to the pain on the elbow, and then directly we say, you have tennis elbow, okay? And this is a real scenario. I know that a lot of people do this. They don't even look at the patient. They don't even examine the patient. They just, where is your pain? Your pain is here. Is it going anywhere? No, okay. Do you have neck pain? No, okay. Tennis elbow, yeah? So I want to try to change this concept in this 15 minutes. I try to convince you to do some more examinations and maybe detect the other pathologies that you can find. So what could it be? Look how many things it could be. If you have lateral elbow pain, look how many things it could be. It could be one of all these things. It could be an extra-articular problem, like the lateral epicondylitis or the tennis elbow. It could be a nerve entrapment. It could be a posterolateral radiocapitellar instability. It could be the Anconius syndrome. An intra-articular pathology, it could be the synovial plica, an OCD of the capitellum, Panner's disease in infants, and radiocapitellar osteoarthritis. So it could be many, many things. So if you just base yourself on the localization of the pain, then believe me, 1 out of 2 times you might be mistaken. So I will go through not all because there is not enough time to cover all the pathology, but the most common ones. So lateral epicondylitis or tennis elbow was first described in the 1800s, and then more, as tennis elbow came up, It is actually an overuse of the wrist extensors and the supinator muscle, mainly the extensor carpi radialis brevis. It's quite common. It involves both males and females, and mainly in the dominant arm. So how does it present? What does the patient describe? He describes pain in the lateral part of the elbow. It radiates down the arm. He has a weaker grip due to the pain, and he can palpate or show you the pain on the lateral epicondyle, and it can reproduce your patient's pain. Of course, there is a big number of tests that we can do. I like the Mill, Cozen, and Modley test. I usually go for Mill and Cozen usually, and these give me a good idea of the presence of the pain or not. Then you think of what images you need to do or how to confirm your diagnosis. And just by clinical exam and say, well, it's tennis elbow, go on and take some painkillers and let's get an injection, in my opinion, is not enough. I would definitely start with a normal X-ray if the patient is, not been too long, and if it's been a chronic issue of more than 3 to 6 months, I would probably go for an MRI. Now, the treatment options are various, but I think everybody merits to start with the medical treatment. The bracing at night, and the wrist, and a slight extension. Maybe some people like to use the tennis elbow brace, which is more on the proximal part of the elbow. Of course, you should rest. You should avoid the triggering factor, non-steroidal anti-inflammatory. I have put in red the things that I think are the most important, in my opinion: physiotherapy and eccentric exercises, shock wave treatment, and injection of the platelet-rich plasma, in my opinion, is superior to the corticosteroid due to the newer studies that prove the higher risk of iatrogenic LUCL injuries and injuries to the tissues underlying, and the more prominent risk of surgery after multiple corticosteroid injections. The surgical options are as follows. You can go for a percutaneous release, an open surgery, or an arthroscopic surgery. It's not very common, to be honest, that I take my patients to surgery from tennis elbow. Most of them, 90% and above, resolve with the medical treatment. Now we go to the next topic, the nerve entrapment. So nerve entrapment in this area, you would think which nerve would pass here. There are actually the radial nerve before the bifurcation, and then the posterior interosseous nerve, and the lateral antebrachial cutaneous nerve. So the lateral antebrachial cutaneous nerve I will not cover in this talk. It's mainly a sensory pain that just is limited to the mid part of the forearm. In the trajectory of this nerve's coverage, and here you will feel more of a numbness and pain that is nerve-like in this area. But we will go through the radial tunnel and posterior interosseous nerve syndrome, and we will try to differentiate between these two. So this is actually not so common. It's a rare condition, but you should keep your mind there that it can exist in some cases. So what is the definition first? It's the compression of the pin, the posterior interosseous nerve, as it passes through this radial tunnel, but it does not give any motor or sensory deficit. It's what we called before a tennis elbow that's not resolving. It's not resolving. The pain is more diffuse, and the pain is not on the classical lateral epicondyle. It's 5 centimeters more distal, and if you press in that area just under the supinator, the patient can have a very aggressive pain. Okay? And it is increased, of course, with resisted active motion of the fingers and the wrist. As you know, the radial nerve originates from the neck, so beware. Sometimes it's a neck issue. You should think of that. And then it innervates triceps and the wrist extensors. It goes down through the arcade of Frost, which is this area between the supinator, where we usually find the compression. It is not the only place, because we can find it in multiple places of compression, the radial nerve, but in the sake of the talk today, I think the arcade of Frost is the area that we should concentrate on. So you can also go for a radiological exam. Of course, the X-ray is compulsory, and then the EMG is usually not contributive because there is no weakness and no sensory loss in the radial tunnel. And the MRI can sometimes show these ganglion cysts from the proximal radio-ulnar joint that compress the nerve. How do I treat it? I start, of course, with the non-surgical treatment, rest, brace, activity modification, and I don't think you should ever think of giving an injection in this area. It's quite risky. And then you go for the surgery if it doesn't work. So it's an approach a little bit more distal to the lateral epicondyle. You aim to go for the supinator muscle, and then you split the supinator muscle. You see the tagging of the radial nerve in the red in the middle picture, and then the release here of the muscle in comparison to here. It's only the superficial part of the supinator that we release. Now, what is the difference between radial tunnel and the pin syndrome? So the pin syndrome is also compression of the nerve, but this time it's giving you weakness. So the patient has a weak wrist, a weak hand, a weak finger, and he feels numbness, pain, all the signs that you would suspect from somebody who has a nerve compression. And this time I think the EMG is really contributive and can help you diagnose and differentiate between the radial tunnel syndrome and the pin syndrome, okay? So now we have finished the nerve part. Now we go to the intra-articular part. What other causes of lateral elbow-sided pain? So now we have already covered 4. We go on. The intra-articular plica. Of course, the knee surgeons know the plica, but the elbow, it's quite important, and it really gives some symptoms. Sometimes in the knee we don't believe it, but now in the elbow we have to believe it because it actually does exist. What is it? It's the inflammation and the thickening of a normally present synovial tissue in the radiocapitellar joint. It's a very small joint here between the radial head and the capitellum, and after it inflames and thickens, it starts to irritate and gives you tenderness, catching, snapping, and deficit of extension. Okay, and we see it with MRI. We see 2 forms. The posterior part, which is this thickening here. This thickening can bother the joint in the space, and sometimes we see the anterior form, but it's really rare. And how do we treat it? Of course, we rest, we change the activity, we do physical therapy, we go for non-steroidal anti-inflammatory, and this time an intra-articular corticosteroid injection through the soft point is often helpful, but transitory. That means comes back. And then we think of the arthroscopic shaving of the plica, very simple procedure. You go in, you shave it, and it's done. Now the next topic we go through is the instability. This is quite rare. It's described in 1991. What happens is a dislocation of the radial head or subluxation over the capitellum, and it can be caused by a fall or a trauma, repetitive valgus force with axial loading, or from the surgeon or the doctor. He gives you so much cortisone, 10 times, 11 times. He doesn't know where he's going, no ultrasound guidance, directly in the bone and piercing the tissues, pushing through the tissues, go posteriorly and cut through the LUCL, and the patient would develop an instability from the elbow. Or you saw a patient coming from another surgeon, he's done a tennis elbow surgery, and he's now complaining of more pain than before, and he feels that he cannot use his arm because this bone is popping out and popping back in. So it's crazy. He said he came for one thing and he left with another thing. So what happens, this ligament here, part of the lateral collateral ligament, which is the LUCL, lateral ulnar collateral ligament, gets injured. And this passes directly over the radial head. So imagine that if it's not there, the radial head would come out on the lateral aspect. How do you examine it? You can examine it with the pivot shift test, which I find extremely difficult to do in the clinic. I have not done it before. It's really hard. You need the patient really relaxed. I start with the push-up chair test. So I ask the patient to push up with his arm in pronation and then in supination and see if there is any feeling of instability in the radial head. If it's that, then I try to do the pivot shift test while patient is lying down, and I try to push and all that. And I think the most important imaging to do is the stress X-rays plus the MRI to see if there is a gap opening in the lateral collateral, in the lateral aspect of the joint. If it doesn't work, usually it doesn't work medically, then we go for an LUCL or lateral ulnar collateral ligament reconstruction. You can do that now with repair and internal brace, or you can use tendon to the palmaris, or sometimes part of the triceps tendon, and you can repair the lateral collateral ligament. Now we move to more bony pathology, the osteochondritis dissecans, and this is a pathology that occurs in younger individuals who have not completely fused their bones. It's usually on the capitellar side and has multiple factorial factors like vascular, inflammatory. Really, we don't understand the whole scenario of why the OCD happens. It does occur more in gymnasts and weightlifters at a young age. So we look out for these young people. We don't just neglect and say, oh, well, you have an inflammation of the tendon. We actually go look for the x-rays and the images. Clinically, you would see worsening and then locking sometimes with stiffness, and the x-rays usually show these pathologies, and on the CT scan, on the MRI, we do see these holes in the bone on the capitellar side. There is some grading, the Minami classification and the Takahara classification, that help us to decide whether to go for the surgery or not the surgery, or wait and brace. But I think the non-surgical option in the early phases does work. You stop all activities immediately, you hinge the brace, and then you do progressive return 3 to 6 months to the sport if that patient is a sporty. And usually they improve at 6 months. If not, then you do the surgical treatment. Usually it either is an excision of the fragment plus micro-fracturing, or an Oates procedure where you try to reconstruct the graft and put a graft into the capitellum. Now, I try to conclude my talk. I know it's been a lot of information in the last 15 minutes. It's exactly on time, so I'm giving you the take-home message. Not every lateral elbow pain is tennis elbow. I recommend you examine all your patients and think of extra-articular, intra-articular pathologies. You should investigate with X-rays, MRI, and EMG if you're suspecting a nerve issue. And maybe I'll let you do this at the end of the day. Thank you very much for your attention.
Any question for Dr. Ali Maqdisi? So the last talk of this hand and elbow surgery sessions will be given by Dr. Hattori. He's a professor in Ogoridiachi General Hospital, the vice president of orthopedic department. He's the Congress president for the 47th annual meeting for general surgery reconstruction in Japan. He did many publications, hundreds of publications in brachial plexus reimplantation and microsurgery reconstruction. And he will be giving a talk today about brachial plexus injury and double muscle transfer.
Good morning, everyone. It is my good pleasure to introduce myself to my all dear colleagues in Kuwait. I am Dr. Hattori from Japan. Today, I'd like to share our experience about functioning free muscle transfer for reconstruction of brachial plexus injury. First of all, I'd like to introduce myself briefly. I come from Yamaguchi City in Japan. Maybe you may know Tokyo, Osaka, or Kyoto, which are the famous big city in Japan. However, Yamaguchi is a small and very quiet city, which is located in the western part of Japan. Yamaguchi is located in the countryside of Japan and is surrounded by the beautiful ocean. There is a lot of beautiful scenery and historical places. When you have the opportunity to visit Japan, I hope that you will not only visit Tokyo and Osaka, but also Yamaguchi. This is my hospital, Ogori Daiichi General Hospital, located in Yamaguchi City. This is a small hospital, including only 182 beds. However, our department is specialized for hand and microsurgery. This is our team for hand and microsurgery. Dr. Do is a world-famous microsurgeon, especially brachial plexus surgery. He is my mentor and is still active for clinical research. We have many international fellows from all over the world. From 1995, more than 40 fellows have learned microsurgery in our hospital. Recently, we have some fellows from Middle East countries. These two guys, Dr. Abdullah Al-Bazaz and Dr. Abdullah Al-Awaji, are very smart, hardworking, and highly motivated fellows with good skills of orthopedic surgery. They are the best fellows in the history of our fellowship program. Both of them come from Kuwait. In my lecture, I'd like to talk about brachial plexus injury. This slide shows the number of cases of BPI in recent 17 years. Our hospital is a center for BPI reconstruction in Japan, and many patients come to our hospital from all over the world. We have more than 400 cases with high energy injury, which needs reconstruct surgeries. The typical cause of BPI is from a motorcycle accident, often with severe multiple trauma. This slide shows a movie of the moment of the accident provided by the patient who recently underwent surgery in our hospital. BPI is a trauma of great social concern in which upper extremity function in young adults is disabled in a momentary accident. Both these movies show a patient with total BPI changing clothes. As can be seen, control of the affected upper extremity is completely impossible. Patient must use a healthy upper limb, mouth, or foot to control the clothes and the affected upper limb. You can understand that the BPI patients have significant ADL impairments. Dr. Sedon is one of the most famous pioneers for peripheral nerve surgery. Just 16 years ago, in 1963, he recommended amputation, shoulder fusion, and prosthesis fitting as the only available treatment for total BPI. In the past 60-70 years, we have performed 281 free muscle transfers in 190 patients. Among them, 176 patients, that is 93%, were for traumatic BPI. Other indications include acute fracture myelitis in 6, post-upper replantation in 5, obstetric BPI in 2, and radiation-induced BPI in 1. Recently, free muscle transfer is widely used for reconstruction BPI, not only for elbow flexion reconstruction, but also finger function reconstruction. In this lecture, I'd like to talk about basic knowledge of BPI reconstruction using free muscle transfer and double free muscle transfer for reconstruction of total BPI, including surgical technique, post-operative rehabilitation, and our long-term results. Prerequisite for donor muscles for free muscle transfer includes no functional deficit following muscle harvest, anatomical characteristics suitable for microsurgical transfer, such as having a single dominant vascular pedicles and a single motor nerve supply, powerful strength, and long contraction length. Gracilis is the most useful donor muscle for free muscle transfer. In the recent past, we have rarely or never used other muscles, such as rectus femoris, for free muscle transfer. This slide shows the cases following single gracilis muscle transfer for elbow flexion reconstruction. Gracilis is a parallel muscle, and its volume may seem insufficient to flex elbow. However, clinical experience shows that a single gracilis muscle transfer provides good elbow flexion, presumably due to muscle strength exercise during post-operative rehabilitation. Prerequisite for donor motor nerve includes no functional deficit following the nerve transaction, possesses more motor fascicles, close proximity to vessels, and easier motor re-education in post-operative rehabilitation. Donor motor nerves available for free muscle transfer include spinal accessory nerve, intercostal nerves, phrenic nerve, ulnar nerve, and motor branch to a single muscle, such as thoracodorsal nerve. Spinal accessory nerve is the best donor motor nerve for BPI reconstruction. However, associated injury of this nerve is not uncommon. In a recent series, 21% of BPI patients had associated injury of spinal accessory nerve. The nerve is frequently injured at the posterior margin of sternocleidomastoid muscle, and the patients present with difficulty in shoulder shrugging due to upper trapezius palsy. A healthy recipient vessel with adequate blood flow are prerequisite for a successful free muscle transfer. End-to-end anastomosis should be the first choice. No scar formation around the vessel is important to avoid post-operative vascular compromise. Recipient vessel should be close to the donor motor nerve. When spinal accessory nerve is used as donor motor nerve, the recipient vessel should be located around the clavicle. The possible candidates are thoracoacromial and transverse cervical arteries. When the intercostal nerves are used, the possible recipient arteries are thoracodorsal, circumflex-scapular, and lateral thoracic arteries. However, subclavian artery injury associated with BPI is not uncommon. In our recent series, 15% of the patients had vascular injuries. Typically, subclavian artery injury is associated with scapulothoracic dissociation. Vascular injuries affect the selection of reconstructive procedures for BPI. There may be a paucity of appropriate recipient arteries with adequate blood flow for free muscle transfer. In single joint reconstruction, such as elbow flexion, placement and routing of the muscle is simple. However, many muscles in the human body cross 2 or more joints. Free muscle transfer can cross 2 or 3 joints too. In simultaneous multiple joint reconstruction, such as elbow flexion and finger function, bowstringing of the muscle is a serious problem. Bowstringing disperses power required to move the target joint, thereby reducing the efficacy of muscle transfer. To prevent bowstringing, the pulley system is imperative to negate this power dispersion. Muscles around the elbow joint, such as brachioradialis or pronator teres, are available as a reliable pulley system. The most typical indication for free muscle transfer for BPI is single muscle transfer for elbow flexion reconstruction in chronic cases. Other good indication is for finger function reconstruction in total BPI. In double muscle transfer, 2 gracilis muscles are transferred for finger extension and flexion, respectively. In triple muscle transfer, adductor longus muscle is transferred in addition to 2 gracilis muscles for augmentation of elbow flexion. In 1995, Dr. Doi developed double free muscle transfer to restore prehension following total BPI. Now this technique is well known as Dr. Doi's procedure. After 1995, we have been performing this technique and have published many articles regarding long-term results, pediatric cases, rehabilitation, and cure recovery. From 1990, 153 patients underwent double muscle transfer in our hospital. In this series, I'd like to show our results of 124 cases, which followed for longer than 2 years. The patient's median age was 24 years. Follow-up length was median 34 months. First free muscle is transferred for reconstruction of elbow flexion and finger extension. Proximal origin of the muscles is attached to lateral clavicle and distal tendon to EDC tendon. First free muscle is neurotized by the spinal accessory nerves. 4 or 3 months after the first muscle transfer, second free muscle is transferred for reconstruction of elbow flexion and finger flexion. Proximal origin of the muscle is attached to second and third rib, and distal tendon to FDP tendon. Second free muscle is neurotized by the 5th and 6th intercostal nerve. Concurrently with the first free muscle transfer, shoulder function is reconstructed too. When proximal stump of C5 or C6 is available for nerve repair, nerve graft is performed for reconstruction of shoulder function. When the C5 stump is not available, contralateral C7 or phrenic nerve is transferred to suprascapular nerve. Similarly, intercostal nerves are transferred to motor branch of triceps muscle for elbow extension reconstruction in conjunction with the second free muscle transfer. Also, sensory branches of intercostal nerve are transferred to median nerve for sensory reconstruction of the hand. I would like to show the surgical technique of double muscle transfer using movies. First, I'd like to show the technique of gracilis muscle harvesting. The design of the flap is transverse in the proximal region of the femur and small incision distal thigh and knee. The margin of the flap is incised. I touch the gracilis adductor longus tendon because the flap is survived of the perforators between adductor longus and gracilis. So we should include a septum between adductor longus and gracilis. The gracilis is dissected around the gracilis. The vessel loop is inserted around the gracilis muscle. So distal is blunt dissection by the dissector. Yes, the attachment of the knee is dissected and the distal dissection is completed. Then I am dissecting the neurovascular pedicule. This is a vascular pedicule, usually 1 or 2 centimeters proximal. There is a motor nerve to the gracilis. This is the adductor longus muscle. There is some branch to the adductor longus muscle from the nutrient vessel of the gracilis. We carefully irrigate these small branches. And then we dissect it until origin of the deep femoral arterial vein. This is now you can see the good contraction of the gracilis. So dissection is completed. This is a nerve and artery. Then we cut the origin of the gracilis. So let us now appreciate the surgical technique of first free muscle transfer In this case, C5 root stump was available for reconstruction of suprascapular nerve. C5 was repaired by the nerve graft to the suprascapular nerve. Actually, this surgery is about 14 hours, but I summarized only 3 minutes. The transverse cervical incision was used to identify a C5 root. Incision along the clavicle and deltopectoral grooves were used to identify spinal accessory nerve and thoracoaccumbral artery. This is a spinal accessory nerve. This is a stump of suprascapular nerve. This is a thoracoaccumbral artery and cephalic vein. The muscle, gracilis muscle, inset through the subcutaneous tunnel of the arm. The proximal origin was attached to lateral clavicle. The vessel repair has already done. This is a thoracoaccumbral artery and nutrient vessel of gracilis. This is a zural nerve to reconstruct C5 root. C5 root was repaired by zural nerve to suprascapular nerve. This is a C5 root stump. This is a zural nerve graft, and this is a suprascapular nerve. This is a spinal accessory nerve. And this is a motor branch of the gracilis muscle. Finally, EDC tendon was sutured to gracilis by the multiple interlacing suture. Tension of the tendon suture is very important for satisfactory functional outcome. In 45 degrees of elbow flexion, MP joint of fingers were fully extended. In 90 degrees of flexion, MP joint of fingers could be partially flexed. This is a final view of the surgery. Next, we shall review the surgical technique of second free muscle transfer. In this case, third and fourth intercostal nerves were transferred to radial nerve branch supplying the long head of triceps for elbow extension reconstruction. Sensory branches of second and third intercostal nerves were transferred to median nerve for sensory reconstruction of the hand. Fifth and sixth intercostal nerves were used to re-innervate gracilis muscle. Actually, this is a 15-hour surgery, but I summarize only 2 minutes. Through the medial arm to anterothoracic incision, vessels and all nerves were explored. Three, four, five, six intercostal nerves have already explored. This is 6, 5. This is a median nerve. This is a radial nerve, and this branch is a long head branch of triceps muscle. This is a sensory branch of intercostal nerves. This is a thoracodorsal artery and vein for muscle transfer. So 2 sensory branches of intercostal nerve anastomosis to median nerve. 3 and 4 intercostal nerve are connected to radial nerve for triceps muscle. This is a 5 and 6 intercostal nerve, later connected to gracilis motor branch Muscle was inset through the arm subcutaneous tunnel. The proximal origin of the muscle is attached to second and third rib. The vessel repair has already done. Thoracodorsal arterial vein was anastomosis to gracilis nutrient vessels. Gracilis motor branch anastomosis to fifth and sixth intercostal nerve. This is the final view. The tension of the suture is very important. In elbow flexion 90 degrees position, the finger can be passively extended. The rehabilitation after free mass transfer is one of the most important aspects to achieve the satisfactory outcome. The upper extremity is immobilized in air back until 4 weeks, and use of arm sling is recommended thereafter. EMG biofeedback training is started after the evidence of re-innervation of the transferred muscle. Passive arm exercise for fingers and wrists are started at 1 week. Among these programs, early passive mobilization is the most important. I'd like to show the detail of early passive mobilization technique. Transferred muscle start contraction at most 5 or 6 months after surgery. During the period, the muscle does not actively move. Thus, adhesion of transferred muscle can easily occur and may lead to poor results. As shown in the figure, the most common site of adhesion is around the pulley. Passive mobilization of finger and wrist produced passive tendon excursion of about 25 millimeters, thereby placing tremendous importance on this method to prevent adhesion. Realizing this significance, we start early passive mobilization technique to prevent adhesion 1 week after surgery. This video demonstrates the intraoperative and post-operative view of passive immobilization technique. This is the intraoperative view. Gracilis tendon was sutured to FDP. Passive motion of wrist and fingers produced 25 millimeters of passive excursion of the tendon. This is a post-operative view of the same patient. 1 week after surgery, early passive mobilization was started. Passive motion of wrist and fingers produced passive excursion of the tendon around the pulley. As secondary procedures, shoulder orthosis was performed in 6 cases to stabilize the shoulder. Contralateral lower trapezius transfer was performed in 9 cases. This procedure is useful to reconstruct external rotation of shoulder. Wrist orthosis is useful to stabilize the wrist and improve the finger function. 66 cases underwent wrist orthosis. In the final stage of reconstruction, correction of intrinsic malus deformity of fingers is frequently necessary. Depending on joint stiffness and the balance of strength between finger extensors and flexors, PIP orthosis or MP joint capsulosis was performed. The results of shoulder function, which was provided by suprascapular nerve repair using C5 root, contralateral C7 or phrenic nerve are shown. Phrenic nerve transfer provides better range of shoulder abduction than contralateral C7. There are no difference in shoulder arc of rotation between the 3 procedures. Range of elbow flexion was median 115 degrees. Power of elbow flexion was 13% of an involved healthy side by Kincombe and 16% by HHD. Results of elbow extension are shown. M3 strength was achieved in 26% of patients, M2 in 37%, and M1 in 26%. More than M2 strength of elbow extension was enough to stabilize the elbow, while transverse muscles were moving the finger. 63% of patients obtained more than M2 elbow extension. Total active motion of fingers were median 44 degrees. 31% of patients achieved more than 60 degrees of turn, which was ranked as excellent. 78% achieved more than 30 degrees of turn, which was assessed as satisfactory recovery. However, 22% could not obtain satisfactory finger function. Sensory recovery of the hand is also very important for finger function. 22% of patients obtained S2, protective sensation in median nerve territory of the hand. 48% restored S1 deep sensation. However, 30% did not have any sensation of the hand. This is the result of the questionnaire to the patients. The question is, do you use your reconstructed hand in daily activity? 20% of patients always use the hand. 21% sometimes use the hand. However, 20% of patients never use the reconstructed hand in their daily activity. I'd like to present a summary of recent cases. An 18-year-old male patient with right total BPI underwent double muscle transfer, suprascapular nerve repair with C-hub root, wrist arthrodesis, and PIP arthrodesis. Clinical outcome 7 years after surgery are shown in the movie. This is a shoulder abduction. This is a very good result for shoulder function. This is a shoulder external rotation. This is an elbow flexion. This is a finger function. He has already done PIP joint orthosis, so main motion in the MP joint. She can hold a heavy object with both hands like this. After surgery, he can easily change the clothes due to he can control the shoulder and elbow. This is surprisingly he can run because he can control the shoulder and elbow. So double muscle transfer is the most reliable procedure to restore prehension in total BPI. However, there are some problems to solve. This procedure needs 2 long and complicated microsurgeries and long-term rehabilitation. Moreover, not all patients undergoing double muscle transfer use the hand in daily activity. The solutions are strict indication for surgery and modification of surgical procedures. Elderly patients and high BMI is a worst prognostic factor for this technique. Thus, such patients are not good candidates for double muscle transfer. In free muscle transfer technique, placement and routing of the gracilis muscle can be modified. In the secondary procedures, reconstruction of shoulder external rotation and forearm supination may be more important and should be reconstructed. This is the final slide. In 1963, Dr. Seddon published a famous article entitled Nerve Grafting. In this article, world's first case of intercostal nerve transfer to musculocutaneous nerve was reported. A 17-year-old lady underwent this surgery after forearm amputation. Good elbow flexion was successfully reconstructed. In right case, I'd like to show my case of the finger function reconstructed with double muscle transfer. Although case report by Seddon was epoch-making for the treatment of BPI. I hope you can understand the remarkable progress of BPI reconstruction over the past 14 years. However, many issues still remain to resolve, and I would like to continue to hardly work to improve aided function of BPI patients. Thank you for your attention, and thank you for your kind invitation to this meeting. Thank you.
Any question for Dr. Hattori? Dr. Talib.
Actually, regarding the sensation, if intercostal nerve, first and second to median nerve, what is your result in this regard?
Yes.
What is your result in this regard?
Sensory.
Sensory, I know.
Okay.
The patient, he get a good sensation after that, or accepted sensation or no?
This is a S1 means in semester test 6.6, so number 20. This is a deep sensation. However, S2 is better than 4.31, number 11. So about 22% of case has protective sensation.
Protective sensation.
22. Of course, not very excellent, but not very bad regarding the severity of injury.
Yeah. What is your proper time to do this surgery? I mean, after injury.
You mean, pardon? Or no?
Yeah, I mean, what is a proper time to do this surgery? Because you mentioned the break request, no previous surgery for the patient. You mean no exploration for any nerve before doing this surgery, right? Mm-hmm. So what is your proper time to do this muscle transfer?
Because you know that we always reconstruct the shoulder function and also triceps function, triceps muscle function by nerve transfer or the C-hub repair. So it should be reconstructed at least within 6 or 8 months after injury. Otherwise, you know, the result is not good. So earlier is better, of course.
Regarding this all secondary procedures, I imagine all brachial roots are avulsed.
Yes.
In this situation. For this, you search about extra plexus neurotization. Mm-hmm. Because all plexus are avulsed, I think.
Professor, a question. If in the cases where you present the contralateral trapezius for external rotation, you presume that the spinal accessory on the same side is injured, or you would have used the trapezius of the same side. What makes you use the contralateral trapezius rather than the same lateral?
It's a very good question, because we use the ipsilateral spinal accessory now by free muscle transfer.
Okay.
Dr. Ali.
For geriatric, you said it's not a good candidate for double muscle transfer. What do we do for geriatric with PPI? Do we do like joint fusions, or what is the solution?
Geriatric.
Yeah, what is the solution?
Child case? Geriatric?
Yeah.
Elderly.
Old.
Elderly.
Elderly, yeah.
Of course, we can do this surgery in elderly patient, but of course, nerve recovery is not good in the elderly guy. And also, this is a very big surgery. Maybe they cannot tolerate this big surgery. So maybe in the elderly patient with BPI, just only simple nerve transfer like intercostal or such surgeries available. Maybe this surgery is not indicated.
Professor, you did not report on donor site morbidity. You have any donor site morbidity on the lower limbs?
You mean the donor side of the gracilis?
Gracilis, adductor. Have you reported this? I don't know your publications.
I did not investigate the donor site of gracilis by myself, but from the report, they said about 9% of 10% decrease of adduction strength. But in my patient, the patient never complained and the weakness of the lower leg, lower extremity. And also after the spinal axis nerve transaction and the intercostal nerve transaction, no donor side mobility.
Thank you.
Dr. Hattori, I have a question. If you use the phrenic nerve for free muscle transfer, you don't afraid from respiratory distress?
So from our result, usually after phrenic nerve transaction, percent VC is decreased about 15%, 15. Before COVID-19, we don't concern about such problem, but after COVID-19, we rarely use this phrenic nerve because later respiratory problem. So recently, we rarely use the phrenic nerve, or maybe never use phrenic nerve.
Thank you, Dr. Hattori. Thank you very much.
So we finish the hand session now, and now we have some honoring the speakers who speak for the hand session. So, Dr. Mohammed Abu Shehri, please take your honor. Next, Dr. Mohammed Abu Al-Ata. And Dr. Ali Maqdasi. And finally, Dr. Hattori. We would like to thank all the speakers. And by this, we finish the hand session, and we'll see you at 11 a.m. for the shoulder session. Thank you.